Okay, so we just looked at our IV start. So we have a good patent running IV. We said we had a patient who was dehydrated, so we were giving him some fluids, reassessing blood pressure and lung sounds, kind of doing that. If we've made a determination that we've got a patient and they're symptomatic and we're now looking to be able to administer medication to them. So this station is kind of a progressive station, so when you do it in school, clearly in the field, we're looking at our clinical findings and following our protocols. So here, if we've been given a scenario that we've got a patient, their heart rate's 48, they've got a blood pressure of 70/40, we're setting up to put them on the pacer, and while we're setting up to get them on the pacer, we want to go ahead and give them our first line medication. So from this scenario, we kind of deduce, okay, we've got a patient with symptomatic bradycardia. We're going to try to get them on the pacer. We want to give our first line drug. So our first line drug is going to be ATROPINE. So now what we do is we look at the drugs, you open your drug book, and now we're looking for ATROPINE. So this is where, as we start to go through this, you want to make sure that you're always reconfirming allergies and that you're always going through your 5 rights. It's not enough to just be like, hey, right patient, right dose, right time. Because if I want to give ATROPINE and I'm holding lidocaine and I just say the 5 rights, right patient, right dose, right time, right route, I'm good. You're not good because you're holding the wrong medication, so that did absolutely nothing to prevent you from creating a med error. So when you pick this up, if you're going through, right, you want to give a medication, so you want to confirm with your patient. So, Mrs. Jones, I know I asked you last time if you had any allergies. I just want to confirm, have you ever had a med called ATROPINE? If you have, has anything happened? If they haven't, okay. And just confirm it again, no allergies. All right, or reconfirming if they said that they had an allergy, what the allergy was to. Making sure that the allergy isn't something that's contained in the medicine. Somebody has a shellfish allergy. We'll have to say, oh, well, we're not going to give you any lobster or shellfish today. But it's usually the iodine in the shellfish. So this is where now I would want to know that, because if the patient has an iodine allergy, I wouldn't want to give them a medication like amiodarone. Or I'd want to let the hospital know that they shouldn't get CT dye when they get to the hospital. So it's not enough to just ask about med allergies. We want to make sure that we've confirmed and we've asked about all allergies. All right, so just confirming no allergies, and you've never had a medication called ATROPINE. And then again, I want to get consent. So Mrs. Jones, your heart rate's a little low, blood pressure is low, which is contributing to feeling kind of weak and dizzy. What we'd like to do today is I'd like to give you a medication called ATROPINE. Ideally, this is going to get your heart rate up, get you feeling a little bit better. All right, and we're going to try another intervention, see if we can get you feeling a little less weak, less dizzy. Are you okay to this? Yes, all right. So I go through my 5 rights. I make sure that I'm holding my atropine sulfate, 1 milligram in 10 mLs. So in order to give the dose of 1 milligram, they're going to get the full 10 mLs in here. It tells me my concentration on hand, 0.1 milligrams per ml. I would make sure that this box had not yet been opened, right? So we would use a new box. If there had been anything tampered, we'd get rid of it. I'm making sure that it is within expiration, all right? We'd open up the box. As I take it out, we assemble our med. I'm making sure that it's capped, that it is atropine sulfate, 1 milligram in 10 mLs. We're going to make sure that this is in fact what we want. There's no particulates. And this is where now these come vacuum sealed. So there's always a little bit of air at the top. All right. So this is where now we want to make sure that our plunger is right at that 10 milliliters in order for us to administer the correct dose. So these can get kind of tight. So what you want to do, a little trick, is kind of pull back a little bit. That will help you break the seal. So now as we come over our basin and we zero this out, so now that we've got our plunger right at that 10 milliliter line, we were able to do this. We see there's no air at the top, there's no air bubbles. So this is where now we're right at where we need to be. If I don't dispel that air, then when you come in to push this to the patient, the first thing you do, you might as well just say die as you push this into the patient, because you're giving them an air emboli. Now, yes, it may take a lot more air, but again, that's cumulative. So if we don't pay attention to what we're doing, we can cause harm to the patient. So always use safe practices. So, you know, saying something like, well, it's not that much air, if this were your loved one, would that be the attitude you would want your healthcare provider taking care of your loved one to have? So always do things by the book, okay? Anytime we have the potential to cause harm to the patient, make sure that we're doing this correctly. So we've got this zeroed out. We want to give them the 10 mLs. That's going to give us our correct dose of 1 milligram. So this is where now we have this capped until we're ready to give it to the patient, and I want to have my alcohol prep pad. We're going to open this up, and this is where now I want to come in and I want to cleanse, all right, across my medication port. So we're going to cleanse this Make sure that there's no signs of infection. This is a lure connect. This is a lure connect. So this, I'm going to press inward. I'm going to make sure that we have this firmly connected. I don't want to take my thumb off the plunger because right now we're full, but as I start to depress this, if this pressure here is greater than here, things will start to back up. So now as we come in, if our line is running because we're giving fluids, we're going to come in, we're going to kink our line. If you have it shut off, all right, we need to be ready to then open this line. If you have this set to an extension set, you want to be able to follow this with a flush. The flush, whether you do it with a bag or whether you do it with an actual syringe with a flush in it, is to get the medication through the extension set and into circulation. So ATROPINE, all right, we know that this is a fast, rapid push. So we're going to pinch our line right back to the patient, not to back to the bag, not towards the patient. So now as we come in and we're ready to go, we're going to push this, and we're going to push this as fast as resistance will allow us. We push the entire amount. I'm not taking my thumb off the syringe. We now disconnect. This goes in my biohazard container, and I'm going to open up my bag, and I'm going to make sure that this flushes and that my patient now is getting the medication, is in the circulatory system, and then I'm either going to continue administering fluids to my patient, or we're going to set this to TK or KVO. To keep open, or KVO is keep vein open. And that's the volume for that is 1/2 milliliter per minute. So a lot of times people are like, oh, KVO is just halfway down. No, that's administering fluids. So KVO, TKO, whichever one you use, that's where now, if I'm using a 10-drop set, 10 drops equals 1 ml. So 1/2 ml a minute would be 5 drops. 5 goes into 60 12 times. That would be 1 drop every 12 seconds. If I were setting this back to TKO, I didn't want to administer fluids, but I wanted to be able to flush this line. I'd open it up and then set it back to that. If I were giving fluids, I'd go ahead and open it back up and continue to re-administer my fluid resuscitation, as well as watching for signs of infiltration and giving my patient, checking blood pressure, lung sounds, clinical improvement. Now, ATROPINE we gave because we were hoping to see some clinical improvements. So the clinical improvements of ATROPINE is that we should see the heart rate go up. Now, we were doing this while we were trying to set up for transcutaneous pacing. So ideally, we're seeing heart rate increase. Maybe they become less symptomatic, so they're not as weak or dizzy. They're not as nauseous. They don't feel like they're going to pass out. So we're hoping to see some type of clinical improvement. Adverse effects, we may see them become flushed. Now, this medication, if we push it too slowly, this is where, if you're like, oh, I'm going to push it over 1 to 2 minutes, well, now we start to see the kind of paradoxical effects of this. Now, all of a sudden, the patient becomes more bradycardic. So you're like, I see your heart rate of 40, and I bring it down to 20 or even less than that, and now we're working a code. So, these push rates are important to make sure that we're administering them correctly. So this is a fast, rapid push, followed by our flush to get it into circulation. We're going to monitor our patient for the clinical effects. ATROPINE can be repeated every 3 to 5 minutes to a max of 3 milligrams, so that's a total of 3 doses at 1 milligram a dose. And this is where now we're going to kind of monitor this patient. Once we have them on the pacer, then we'd probably stop administering ATROPINE because the pacer is going to take over the heart rate for us, so we're not going to have an increase in heart rate if we've already got them on the pacer. Okay, so this is where now we're looking at what are the effects, why are we doing this, how often are we repeating this, and this is where really knowing those algorithms comes into effect. You want to make sure that we know, okay, we're going to try this while we're setting up, but then once we get them on the pacer, if I have a symptomatic bradycardic patient, they're hemodynamically unstable. Once we've got them on the pacer, if they're not getting any better, we might get that heart rate up, but maybe the blood pressure stays low. Now we're looking to add other interventions like fluids, or potentially now adding a pressor like epi or dopamine or levofed, depending upon what's wrong with my patient. Okay, so the mechanics of going through for the med push is not challenging. It's just making sure that as we do this, we've asked for allergy, we've gotten consent, we've cleansed our port, we've dispelled our air, we push it at the correct push rate, we dispose of it in a biohazard container. A lot of people think that just because this doesn't have a needle on it, if we put it down, that's totally fine. Once you put it down, that's a contamination. So we can get blood draws on these lines, and that's where now different viruses and things like that can live outside of the body for days to weeks. So we never want to take anything that could potentially have bloodborne pathogens and put it down. That becomes a safety concern for us as well. So they always go into a sharps container. The real name for that is a biohazard. We named it a sharps container. So just because something doesn't have a needle on it doesn't mean it shouldn't be disposed of in the correct type of container there. All right, and we'll deal with that at the hospital. Okay, so like I said, simple to go through the mechanics of this. The real big thing here, and the reason why we see students struggle, is because they don't know their drugs, they don't know their doses, and they don't know their push rates. So the mechanic's not hard, but it's really kind of looking and memorizing. What are the indications? Why do I do this? How do I push it? What's the effects? How long in between the intervals until I can repeat these doses? And what's my max dose? What am I able to do within my protocols before I would need to now reach out to med control, or get an idea that maybe this isn't working for my patient. Now we need to either add another intervention, or are we in the wrong protocol? Okay, so that's your med bolus. All right, your IV push. So hopefully this helped you there, and we'll look at our infusion in an upcoming video. All right, so as always, please go ahead like this, leave us a comment. If there's something you want to see, you have a question, something that wasn't clarified in here, please leave a comment below, and we will see you next time. Take good care.